Okay, do you guys have a red record button going?
Yep.
Perfect. All right, Robert, where are you? There it is, okay. All right, I guess Bob will text me, okay. All right, let's talk a little bit about C. diff because this is a growing concern right now. Who works in healthcare right now? Kathleen, don't you?
I work in clinical research, but
Um,
not true healthcare.
Well, I don't know. It's big in nursing homes, and Bob could probably tell us more about it. Yeah.
I used to work in a nursing home.
So apparently, once you smell C. diff, you never forget. Is this true?
This is true.
Very true.
Very, very true.
Yeah, I like almost want to go to a nursing home and get away from that, and I'm like, no. All right, so non-resident of colon.
I was at her house before she went to her training. She said, what do I need to ask today?
Who's
So I
talking?
said, find out.
Somebody asking a question? No, okay. So non-resident of colon in low numbers, and most of us have a little bit of this in our large intestine, right? Causes antibiotic-associated colitis. So anything itis is inflammation, so inflammation of the colon. We'll see a picture of it coming up. Relatively non-invasive. All right, treatment with broad-spectrum antibiotics kills the other bacteria, allowing C. diff to overgrow. Remember, we're killing out everything that's not a spore former. Relatively easy to kill. Spore formers will kill the vegetative cells relatively easily. It's just the spores are left behind. There's no competition. They just regenerate, okay? Produces enterotoxins that damage the intestine. Remember, anything entero is GI. It's releasing these toxins in the intestine, causing major inflammation and diarrhea. Major cause of diarrhea in hospitals, increasingly common in community-acquired diarrhea. Nope. All right, so on the left, we have a healthy colon. On the right, see how pink that is? Completely inflamed. Major C. diff colonies growing there. Mild, uncomplicated cases respond to fluid and electrolyte replacement and withdrawal of antimicrobials. So usually they're saying, we're going to flush it out. We're going to stop the antimicrobials. If you can pollinate your intestines, you don't have a problem. And does everyone know what a fecal transplant is, or have you guys heard of this?
Yep.
Okay. Yeah. So if we can't do it, you can go in. I guess it's capsule form now, or you can get somebody you trust and get a fecal transplant. So you're going to re-inoculate your intestines with normal microbiota. We'll get to that coming up. So just regular E. coli or some things just that you need in your intestine anyway for your microbiome, and we'll re-inoculate that so the C. diff has some competition, and we're going to stop them wiping it all out. So, Clostridium botulism, rare but severe intoxication, usually from home canned food. So we just talked about botulism as a neurotoxin, and porphyringes cause gas gangrene, all right? But remember, these, if we consume them, all right, we're not infected with them, we have an intoxication. So please realize the difference. You're consuming it, it's not causing an infection in your tissues per se, but you're getting it from consumption. So rare but severe intoxication, usually from home canned foods. All right, so please realize you didn't can properly, and if you're canning, you should be using a pressure cooker, which is a cooker like an autoclave or something similar to an Instapot. You're bringing that up to a certain temperature for a long period of time. You're killing the vegetative cells and the endospores. The problem with the consumption of this is you're consuming the food and the spores are still alive. So if you consume it, the spores come back to life. They start releasing those toxins into your intestine. You can get relatively sick from that. Clostridium perfringens, mild intestinal illness, second most common form of food poisoning worldwide. So just realize these spore formers, if you kill the vegetative cells, you consume these spores, they will repopulate in the intestines when the air or the oxygen conditions become low enough, and they just they resurface again. Right? So botulism from food processing, intoxication associated with inadequate food preservation. These are botulism is spore-forming anaerobe, commonly inhabits soil and water. So just remember, when you're canning your fruit or vegetables or whatever, you're picking the spores up on the vegetables. No matter how well you clean them, you need, let's say even you use bleach, you're not going to kill the spores. So they're on the food, you go to can it, you kill everything but the spores. Then when you consume it again, they're going to come back. So the pathogenesis. So how does this actually cause the pathology? Spores are present on food when gathered and processed. If reliable temperature and pressure are not achieved, air will evacuate, but the spores remain. All right, remember now we've canned it. We've taken almost all the oxygen out, or hopefully all the oxygen. Anaerobic conditions favor spore germination and vegetative growth. Potent toxin botulin is released, and we've been able to market that for Botox. All right. So botulin toxin is carried to the neuromuscular junction and blocks the release of acetylcholine necessary for muscle contraction to occur. So literally, it blocks this. The acetylcholine can't pass the synaptic cleft and get that myosin cross bridge to contract. All right. So double or blurred vision. All right. So we're going to be blocking the ciliary muscle. All right, and the pupil, and won't be able to focus. Difficulty swallowing, we start affecting the tongue, the pharynges, neuromuscular symptoms start occurring. Right? So if I asked you guys the difference between botulism and tetanus, would you be able to tell me the difference? All right, so they're both going to cause neuromuscular issues, but kind of be familiar with how each one works. Remember, botulism is going to block the binding sites for acetylcholine. All right, the other one is going to start blocking the inhibitory muscles. All right, so this one, you can't contract, right? That's how Botox works. You can't, the facial muscles can't contract, so you don't have as many wrinkles, all right? The other one, with tetanus, all right, the contraction's strong, you don't have any inhibitory muscles. So neurologically, they're going to be different. One, you stay in contraction. This one, you can't contract, but the mechanism's different. All right, infant botulism. All right, does anyone know what you're not supposed to feed babies?
Honey?
Honey.
Yeah. All right, it literally causes something called floppy baby syndrome. Right? Caused by ingested spores that germinate and release toxin called flaccid paralysis. So the baby literally can't contract to stay upright. So really you have this baby that's just flopping around. It's literally a syndrome, all right? So it does go away. We give them antitoxin, but it's pretty scary. And then wound botulism, spores enter wounds and cause food poisoning symptoms. It's going to enter your wounds, all right? It's going to start releasing those toxins and inflammation into the wounds rather than the GI tract. So we want to be able to determine the presence of toxins in food, intestinal contents, or feces. So if we suspect that, you know, you're going to do a stool sample and just go look, stain it and see what you find, right? Administer antitoxin, cardiac and respiratory support, right? Because, you know, listen, the myocardium is a muscle, right? The diaphragm is a muscle. We can have a problem with that. Practice proper methods of preserving and handling canned food, addition of preservatives, all right? And, you know, I'm sure that your parents told you, or you never buy a dented can, right?
Yeah.
It's okay, right? So, Clostridium perfringens, what does this cause in a wound?
Gas gangrene.
Gas gangrene, all right? But here it says it causes gastroenteritis. So remember, you're consuming this, you're not getting infected by it, but you're getting an intoxication of it. Spores contaminate food that has not been cooked thoroughly enough to destroy the spores. Spores germinate and multiply. When consumed, toxin is produced in the intestines, acts on the epithelial cells, acute abdominal pain, diarrhea, nausea, rapid recovery. So a lot of you, you may have had food poisoning or whatever. You ate something and you got sick. Maybe you had some diarrhea or some stomach cramps. So who knows what it is? You just flush it out. It could have been this. You don't know, right? So here's all the spore-forming pathogens. All right. So just kind of remember, if we're going to ask you a question, we're going to ask you something would be specific to that microorganism. So just kind of know how you'd separate those, or if we give you a question, what would be, what part of that question or case study would be relevant for that organism. So gram-positive regular non-spore-forming bacteria. So these are gram-positive, they do not form spores, so they're a little bit easier to kill, right? So if we kill the vegetative cells, we kill the vegetative cells. They can't reproduce. Spore formers can. So these are regular, stain uniformly, and do not assume pleomorphic shapes. So these are, those rods we saw on the very first slide. They look like baseball bats or clubs or whatever, and they were very different in shape. These are going to be a much more uniform shape, all right? Okay. So Listeria monocyte, all right, so here let's break it down. Listeria monocytogenes, all right? So what are monocytes? Have we talked about those yet? Monocytes are in your blood. When they leave your blood, turn to macrophages. So this is the one, Listeria likes to trick these into, they literally taunt and they get into the monocyte and they get carried all around the immune system. Erythroplexy or listasopathy is usually, it's going to be, if you see a question on this, you're going to have very, very red fingers, very swollen. And usually, honestly, you only see this from like a pig bite. That's what they usually ask you. All right, Listeria monocytogenes is non-spore-forming gram-positive, ranging from coccobacilli to long filaments. Right? These have flagella, they lack capsules, so they're mobile. You can see it right there. Lactitious, right? Resistant to cold, heat, salt, pH, and bio. Right? Remember, bio, I'm sure they told you in A&P or whatever, that bio was there to emulsify fats, right? Okay. Mm-hmm. The other thing, it's there, it kills a lot of bacteria in the intestines. So bile does emulsify fats. It also kills a lot of bacteria in your GI tract. But this is resistant to cold, heat, salt, pH extremes, and bile. So you could put this in the refrigerator, or there have been cases where this stuff will grow on ice cream. Right? You can change the pH, it's resistant to it, it's resistant to high salt, so it's in a lot of processed lunch meat. Virulence attributed to ability to replicate in the cytoplasm of cells after inducing, it literally induces phagocytosis, avoids humoral immune system because your blood thinks this is totally normal because it's a monocyte. It's one of your own. So it literally induces it to consume it, right? And now it's literally growing in the monocyte. So it's entering like this, replicating, and then leaving. Primary reservoir is soil and water and animal intestines. So realize this is in soil, and when, if you guys have ever seen Food Inc. or any type of meat processing plant, you can imagine when they got these things, the intestinal contents can get everywhere, all right? So regardless of what you were told in elementary school or high school, most of the meat in the country doesn't come from Sunnybrook Farms, over in Springville or whatever. It's going to come from a meat processing plant. It can contaminate food and grow during refrigeration. Listeriosis, most commonly associated with dairy products, poultry, and meat. And this has vertical transmission. If you guys remember what that is. All right.
Is it mother to baby?
Yeah, so it's transplacental. This can literally cross the placenta. Often mild or subclinical in normal adults. We wouldn't have a problem with it. But once again, this is one of those, If the patient's immune compromised, they got something else going on, cancer, diabetes, other therapies, their immune system's already kind of busy. Fetuses, neonates, and it can affect the brain and meninges, especially in the immune compromised or fetus. 20% death rate in this population. So us, there might be under 1%, but this, the death rate's a little bit higher. Because remember, this is going to get into your monocytes, and it can travel anywhere in your body or your bloodstream and get out wherever it wants. So it can spread very, very quickly. Diagnosis, culture requires lengthy cold enrichment process because it grows in the cold, plays the cold. So we're not going to do that. We're going to do an ELISA test or check DNA or antigen antibody. We want a quick response to that. Right, prevention, pasteurization, and cooking. So you'll always say, mothers or pregnant women shouldn't consume lunch meat and so on and so forth, because we're just a little bit worried about that. Rhipsoplexus ruthopathy, gram-positive rod, widely distributed in animals in the environment. Primary reservoir, I said this comes from the tonsils of healthy pigs. So it's going to be a pig bite, usually is going to be what they're going to ask you, some weird thing like that. NSU skin abrasion multiplies to produce the toxin, dark red lesions, right? And vaccination for pigs. So I don't think I'm going to ask you that question, but if you ever see it, it'll be some kind of zoonotic infection. All right, so gram-positive irregular non-spore-forming bacilli. All right, so generally we get to the end of these chapters and nothing genetically is 100% similar. So we try to classify these by gram-positive rod, gram-positive cocci, gram-negative rod, or whatever. So at the end of a lot of these chapters, there's no real place to categorize them. So these are irregular, pleomorphic, stand unevenly. So pleomorphic, somebody remember what that means?
Change shape, right?
Yeah, so morphic is shape. So these are going to be different shapes. They're never exactly the same. So they usually, a lot of these, sometimes they'll actually take on the shape of whatever they touch. All right, these stain unevenly. So sometimes we don't even know if they're going to be gram-positive or gram-negative because they stain so non-uniform. So Corynebacterium we'll talk about, Propionibacterium for acne, Mycobacterium we'll talk a little bit about, and then I'll mention these a little bit. Not that clinically important for me. So just showing you pleomorphism, Corynebacterium diphtheria. What do you think that causes?
Diphtheria.
Diphtheria, yes, very good. Yes, so always read the name, it'll tell you. All right, palisade arrangement. So whenever you see that, that's kind of like a picket fence that's broken. They're going to kind of lean like a picket fence. That's palisades. Epidemiology. All right, so where's it come from? Reservoir of healthy carriers, potential diphtheria is always present. So usually this we're carrying around in our throats or whatever, and we inadvertently give it to somebody else. We don't even know we have it. So we're a reservoir of healthy carriers, not or asymptomatic. Most cases occur in non-immunized children living in crowded and unsanitary conditions. So they may not be, showering as much as we are. Their dishes may not be as clean as we are. And these are crowded. So none of us, hopefully none of us have ever been to some place that's really crowded. Like I didn't really realize this until I went to India and I saw people completely crowded conditions, not very sanitary, and public urination and defecation, and it was pretty horrendous. This is really how this gets spread. Acquired via respiratory droplets from carriers or actively infected individuals. So respiratory droplets would be a sneeze or a cough or whatever, where these droplets would be exhaled from the healthy carrier or someone who had it, inhaled by somebody who was not immunized, or somebody who was already malnourished or something like that, to that effect. All right, so here's the pathology, all right? So if they ask you a question, child, that, development of a leathery pseudo membrane, right? So it's gonna be diphtheria. Local infection, upper respiratory tract and inflammation. They're going to have sore throat, nausea, vomiting, swollen lymph nodes. Sorry, it sounds like the regular flu or cold or whatever. The problem is, as this, can you guys see the pointer or the arrow?
Mm-hmm.
As it starts to heal, right, we get fibrotic tissue. And this literally is like almost like a leathery tissue. And what happens is it actually starts covering the back of the throat. So they have trouble breathing. They have to, lance that or cut it and clean it out. It causes asphyxiation. Right. So the toxin targets organs, primarily heart and nerves. Right. So it releases toxins, which is what kills the tissue. The body goes to try to heal it up. It makes all the scar or fibrotic tissue there. Right. So diagnostic methods. How would you know this was not flu or cold? Well, the pseudomembrane and very, very indicative of swelling. You could stain it. Of course, I don't really stain that well. Conditions in history. And what they're going to do, they're going to do the serological assay. They're going to just do antigen antibody or put it in those containers. For your reaction, we kind of know what it is. So treatment, antitoxin if they have it. We want to bind up all those toxins so they don't cause any further damage. The child doesn't get any sicker. All right, prevented by the vaccine series and boosters. So DTaP once again. All right. So Propionibacterium, if you see that, it's going to be a question on acne. It's going to be superficial, gram-positive rods, right? Autotolerant, anaerobic, so they can tolerate some oxygen. They don't use it, but they can tolerate it. It's anaerobic, non-toxigenic. It doesn't really release a lot of toxins. Common resident of the pilosebaceous glands. All right, so it's in the skin, causes acne. It gets deep into that tissue, the inflammation. It's easy for it to have access. It's got, a lot of food supply in there. All right, so Mycobacterium, all right, bacterium, gram-positive irregular bacilli, acid-fast staining. So these are not going to gram stain. All right, you have to heat that up and do with alcohol on a slide. Strict aerobes produce catalase, produce mycolic acids in a unique type of peptidoglycan. Right? They don't form capsules, flagella, or spores, but the mycolic acid in granules, they resist staining a lot. Right? Very resistant to staining. So we'll talk about a couple here. Mycobacterium tuberculosis. All right, bovis is from cow, right? And, I don't know if you know about a lot of the immigrant population or people coming from other countries. They usually have a vaccine for this, and they're going to use this, Mycobacterium bovis, for this. And if they come to the country, they're going to test positive for tuberculosis, even though you don't have it. We've already given them, part of this mycolic acid and part of that, so that our dendritic cells will present that to the immune system, so we'll have some kind of antibodies to it. So they're going to have a positive tuberculin test, TPD. Right?
That's one of the questions that we ask them before we administer the PPDs. Have they had the BCG vaccine, especially if they're from like Russia, anywhere over there, India, of course.
Yep.
Other places in Asia. And a lot of them, they'll know. They'll tell you straight out, like, oh, yeah, we've had it. Okay.
It doesn't mean they're not going to get TB here.
Right.
And it doesn't mean it's 100% effective, but, we also kind of have to realize if we have, I'm not going to get political, but we have a lot of immigrants coming in, whether they're illegal or illegal, we don't know. They could be harboring TB. Right. So just a concern in healthcare right now. So we're going to talk about that. We'll talk about just a couple of these that are relatively clinically important at the moment. So the tuberculin bacillus produces no exotoxins or enzymes that contribute to its infectiousness. So it doesn't release any exon or enzymes that are virulent. All right, but it has virulence factors. It contains complex, waxy waxes around it. All right, so that's going to really inhibit phagocytosis. All right. Cord factor, which is a very, very thick protein. Right? Prevent destruction by lysomes and macrophages. So this doesn't release any toxins, but it's very hard for your immune system to get all of them or consume all of them. So we'll see coming up that if you have this, if you've never heard of a granuloma, the body, if it can't really get rid of something, it'll send a bunch of very large white blood cells, macrophages, out to surround it, to like kind of put a sarcophagus around it or a cement wall so that it can't spread. So if somebody tests positive for this, we give them a chest x-ray. We're looking for this. They're called Gone tubercles or whatever. And inside that, you can have some caseous necrosis. So you have in the interior, whatever was there is going to die. All right. And caseous means cheesy. So it has this cottage cheese consistency, totally disgusting. And the issue we really have with this is if it's sequestered, we don't have a problem. But, you know, think about this. What if your immune system gets pulled away for something else? Like, let's say you have pneumonia or you get some type of cancer, you know, God forbid, your HIV, or, you know, I can mention anything. Your body has to, you know, you only have so much immune system. Your body will leave that area and go fight other things if it can. And then we can have secondary tuberculosis. We'll talk about that here in a minute. So predisposing factors include inadequate nutrition, because, you know, if we're starving or we don't have good nutrition, we may not be able to produce all the proteins we need for our immune system. Right? We may have to ration our proteins for the most important functions. The debilitation of the immune system, if it's called somewhere else, if it's compromised, or, you know, let's say that someone's 80 years old. I mean, their immune system's not going to be as effective as somebody 20, 30, 40, 50. Or access to medical care, lung damage is huge, and genetics. Just kind of remember when we talked about those B cells and things, your body's going to take all of those genetics and shuffle them around. So depending on what you came in with, you may not be as effective at making an antibody. Your B cells may not make an antibody to this. You know, we're not saying that, you know, everyone can make an antibody to everything. We just have millions of combinations. We hope that one of those will trigger an immune response or something. Estimate a third of the world population and 15 million in the US carry tubercle bacillus. Highest rate in the US occurring in recent immigrants. All right, and this, the book I'm using is probably about 4 years old, so I don't know if those stats are quite as accurate as currently, but you get the idea. Bacillus is very resistant, transmitted by airborne respiratory droplets. And I always ask, if we were in class, I would say, well, who thinks that TB is easy to get? And a lot of people think it's easy to get. It has a low infective dose, so it doesn't take a whole lot, but you really kind of have to be exposed consistently. So what kind of population do you think might be more prone to this, if you're thinking about this?
No, I know the homeless have a big problem with it.
Yeah, because they're usually homeless, aren't moving around. They're going to be,
And you don't have good nutrition and
you know, they may be alcoholics. I mean, there's nothing wrong with that drink. Right? Or people that are in, you know, God forbid, prison or group homes or somewhere where they're going to be in proximal to each other for an extended period of time. All right. So, you know, they may be coughing at each other, sharing, you know, silverware or whatever, glasses or whatever it might be. All right. Course of infection and disease. 5 to 10% of infected people develop clinical disease. So it's, you know, like I said, it's not, you know, I'm not going to say it's not serious, but 5 or 10% of the population will develop clinical disease. The rest of us are going to probably, hopefully, take care of it or at least isolate it. Untreated disease progresses slowly. Majority of TB cases are contained in the lungs. Clinical tuberculosis is divided into primary TB, right, which is consolidated usually. Secondary, reactivated or reinfection. So primary, you have it, Your body can't get rid of it completely. It'll sequester it. And then we have something else going on. We may not be able to sequester that completely, and then it can reactivate because we're not holding it at bay, all right? Disseminated is what you don't want. So extrapulmonary TB, disseminated. So it literally leaves the lungs, which are relatively confined, right? Leaves the lungs, and then once it leaves the lungs and gets into the bloodstream or gets into fluids, it can be anywhere, all right? And sometimes they call this military TB because it looks like they'll have these dots all over the body where this is growing. It looks like they were shot with birdshot, literally. So with primary TB, the infective dose, I said it's not very big. You only need 10 cells, right? Not a lot to do it. Phagocytosis by alveolar macrophages, your type 2 alveolar cells, same thing that COVID likes to attach to. All right, multiply intracellularly. So they get inside the cells and they start multiplying. After 3 to 4 weeks, the immune system attacks, forming tubercles. All right, tubercles, a long tubercle. All right, it's a granuloma consisting of central core containing bacilli surrounded by white blood cells. All right, so here's the initial infection. Your body is going to put these white blood cells around. All right, multinucleated giant cells. Right? Granulomas. We're going to surround this and try to sequester it. Right, and I mentioned this before. I said caseous necrosis. All right, so what happens is all these cells in the middle, this cell dies, all right? It just dies, and the body tries to clean it up, but it can't. So that's caseous necrosis. They gradually heal by calcification. So if you go and take an x-ray of someone with this, all right, they're gonna have a white spot, all right? And remember, when you're looking at radiographs or whatever I mentioned before, anything black is gonna be air. Anything kind of gray is going to be connective tissue, might be muscle mass. Anything white is going to be osseous or calcareous, because remember that whatever ionizing radiation you're shooting through, anything calcific or osseous is going to absorb that X-ray. Those rays will not hit the bucky, and they won't develop in anything, so you won't see anything. Right? If something's black, that means the light went through, exposed that film, turned it black. So we know that that area's air are very, very thin. Anything white is going to be very, very dense. It absorbs all the ionizing radiation. Okay. So secondary TB is what we really want to be concerned about in healthcare. If a patient doesn't recover from primary tuberculosis, reactivation of the bacilli can occur. Right? Tubercles expand and drain into the bronchial tubes and upper respiratory tract. All right, so usually they could have a, what's it called? Pancoast tumor, sorry, it took me a minute. In the apex of the lungs, it's called a Pancoast tumor. That'll start impinging on nerve roots and things. But sometimes they'll expand and just start draining. Right? Gradually, the patient experiences more severe symptoms. Violent coughing, greenish or bloody sputum, fever, anorexia, weight loss, and fatigue. So back in the day, before I was born even, they used to call this consumption. People would get so sick, right? It would literally just, if you couldn't get rid of it, it would literally consume the whole body. It would spread so much it would consume the body. And these people would be coughing up green sputum and blood, and that was typical. In England, when this was spread, or whatever, they would be coughing up blood. They had the consumption, they would call it. Untreated, 60% mortality rate. So this can be deadly if it's untreated. You know, if it goes to secondary TB. You keep it primary, usually not a huge problem, but once it goes secondary or military, it's not good. Extrapulmonary, during secondary TB, bacilli disseminate to regional lymph nodes, kidneys, long bones, genital tract, brain, and meninges. So it literally spreads, right? You might see it as military TB as it spreads. And it says right here, these complications are grave. What do you think that means?
That they could die.
They're going to be in the they're going to be in the grave. Yeah, it's deadly. Exactly. All right, so I'm going to talk a minute here too about the mannitol test. All right, so I will be asking you guys. It'll be one of the questions on there, the mannitol test or purified protein derivative or the TB test. All right. So mannitol test, local intradermal injection of purified protein derivative. All right, so we probably all had this, right? So they go in and they stick the purified protein derivative into your skin. You go back 48 to 72 hours later, and we look for swelling and redness. All right. If we have no reaction, what does it mean? If we have a reaction, what does it mean?
Just means that you've been exposed to the bacteria.
Yes, but why? How do we know that if you have a raised red area that you've already been exposed to it?
Because you had an allergic, the bacteria produced an allergic reaction to the intradermal shot.
Well, did it produce an allergic reaction, or did your memory cells from prior exposure?
Memory cells.
Memory cells. So remember, this is how we know if you are injected with a purified protein derivative and you have this reaction, we can say, oh, well, in 48 to 72 hours, your immune system reacted so quickly that it produced this red wheel here. So we know that you were exposed to it before and your body automatically already has antibodies to it. Right? That's how it works. And duration, establish guidelines to indicate interpretation of results based on the size of the wheel and specific population factors. So, you know, like Robert said, or you guys said, if you already know you have the vaccine to it, you've already taken some form of purified protein derivative. So we would automatically, if your immune system's working, we would know you'd have this response. All right, and just depending on how reactive it is to it. All right, and literally this does not mean you have TB. It just means you were exposed to it or potentially exposed to it. It's not diagnostic for having TB. But if you have this, we're going to send you for blood work and a chest x-ray, obviously, right? We want to just see what's going on. So there's an x-ray, and I said anything black is air. This is clavicle, scapula, sternum, cardiac shadow here. But look at how white that is. So that literally is calcium. So this is calcified. There was caseous necrosis there. The body healed it, turned it into calcium. Right? So x-ray direct identification of acid-fast bacilli and the specimen of sputum. Let's see it. Cultural isolation and biochemical testing, which we do pretty rapidly. So management, here's the thing. TB, tuberculosis, goes through binary fission very slowly. Right? And remember, these antimicrobials, I said when we did chapter 5 or 6, I think it was, or somewhere around there, I said antimicrobials are very effective on rapidly dividing cells and usually young cells. So these take 6 to 12 months of at least 2 different drugs because these replicate so slowly. We have to take the drugs for such a long period of time because we have to hit them, or they only really work when those cells are dividing. Okay. So they're going to use refractors, what the common one is now, and it's